And let's face it, they know, right? They know very well. They always ask me those questions, but they're interested in one thing, coverage, right? Because the truth of the matter is, if the FDA approves it, we're going to pay for it. I mean, that's just the
In the
paradigm right now.
oncology setting.
In the oncology setting. Right.
That's not.
So, and they know that.
All right. So, final topic. There's been a series of innovation grants that CMS introduced through CMMI. The most recent has been called an Oncology Care Model. Is it another form of just the medical home? It seems to me it was interesting in that the model grant was released really asking payers to take a role, and whether payers are now serving as aggregators where they can basically put Medicare as a carrot. So payers would probably want to go to episode of care, want to go to bundle payment, want to find a different value-based reimbursement model. And it's not easy to do to get when you're 10% or 20% of a practice's revenue. But if you can put that carrot out there, that not only that, but we're going to bring Medicare along with, it seems pretty enticing. So I guess I'll start with Ted. How is COA interpreting the Oncology Care Model? Is it just consistent with your medical home that you've been endorsing, that COA's been endorsing for the past 2 years? And what is the role, do you think, of the payer as the aggregator? Do you think practices can be in the position of assuming risk, do compliance monitoring, do reporting? I mean, there are a few practices that clearly have the scale to do that, but the great majority don't.
Right. You know, I think, Bruce, it's a step in the right direction. But, and I'll go into the but in a minute, a lot of people, when it actually came out, and I have to tell you, a number of people associated with COA, Dr. Mark Thompson, Dr. Bruce Gould, others that you know, Dr. Barbara McEnany, were actually involved as the Brookings, who was sort of had the contract through MITRE to look at this model and put it together.
More acronyms.
Yeah, sorry. I live in the world, Scott, we live in the world of acronyms. But the bottom line is that a lot of people, when it came out, said that were sort of associated, said, oh, you should feel great. This is very much the COA model, because we've been up on Capitol Hill as they've been working on the recently House-passed, not Senate, SGR bill, and payment reform. We've been talking about our model because we have a specific model that 18 oncologists and administrators basically worked on for several years. The problem is, so there's a step in the right direction. A lot of people say, why does it look familiar? Because there's basically sort of this care coordination fee, and then there is this quote unquote sort of shared savings performance base. The problem with it is, and I give some credit to CMMI that they listened, but they didn't listen to everybody, and they didn't listen to everything we were saying. So for example, when you get down to brass tacks with this, the performance piece, which is sort of based on, first of all, sort of this artificial 6-month bundle, is a problem. But that performance base is more of what we refer to as gain sharing, which is meaning you're competing against yourself, as opposed to shared savings, where you're competing against other institutions, whether they be community clinics or hospitals or whatever. And it's so ironic to me, because what is one of the biggest problems with the ACO model right now after 2 or 3 years? It's because it was built on gain sharing. So basically, practices that are doing well in an ACO or ACOs that are doing well all of a sudden find out they can't do any better because they've corrected it. So here you have CMMI, which is part of CMS, obviously, design a model. We said, do not make it about that. And I think one of the reasons why they actually wanted it is because they feel they're going to take these very inefficient practices that have a low bar, and they're going to do wonderful in terms of that. So you want to compare them against the lowest bar. And I think another good thing, at least on the surface, was not just making this about Medicare, but involving the private payers and trying to get them involved. But there are other stats about this that really, truly have to be corrected before this goes prime time. And maybe one of the reasons why they've even pushed back the date by 2 weeks, that both the payers and the providers have to even submit a non-binding LOI, because there are 34, 36 measures. We don't need all those measures.
This is another example.